So moving swiftly onwards from this meme, this is your first case. I'll put a poll in the chat and you can answer it if you want to. Have a go at this question. Everyone so far has gone for the same answer. This is like a classic second year ESR SBA. So everyone who's answered so far has gone for option D, which is primary hyperthyroidism. Would anyone like to explain why they think it's primary hyperthyroidism opposed to the other options? If you didn't answer and you're not sure, we'll go through it in a minute, so don't worry about it. You can just put it in as a message, like what your logic was to that question. T3, T4 are high, so it's hyperthyroidism. There's negative feedback on the pituitary, which means there's a low TSH. That's exactly why this is primary hyperthyroidism opposed to secondary hyperthyroidism. So thyroid disease is kind of like a massive thing because it's so systemic and it causes so many effects around the body. So today we'll just focus on hyperthyroidism. We can go through hypothyroidism another day. But quick reminder with this nice diagram from Geeky Medics. This is the thyroid hormone axes. And in order to produce T3 and T4, we do require the pituitary to be stimulated by the hypothalamus, and then that in turn to stimulate the thyroid gland itself via TSH. So in primary hyperthyroidism, you have a problem. You usually have a problem with the thyroid gland itself. That's why it's called primary hyperthyroidism, which means you're attracting out loads and loads of T3 and T4. This T3 and T4 negatively feedbacks on the pituitary gland, which suppresses TSH production, which explains the blood test that you would have got in this SBA. Secondary hyperthyroidism is slightly different. So it's usually due to a pituitary, increased pituitary output of TSH. You can sometimes also have an ectopic source of TSH, but the problem is usually with the pituitary. That throws out loads and loads of TSH, which causes the thyroid gland to produce lots and lots of T3 and T4. So both of these are raised in secondary. There is no negative feedback from the raised T3 and T4 because the adenoma within the pituitary gland doesn't respond to T3 and T4. Amazing. So what symptoms will a patient with hyperthyroidism complain of? Note symptoms, not signs. What will they tell you as they walk in to your clinic or whatever? Yeah, so they're quite likely to be anxious. They can be very anxious, feeling hot, shaking, tremor. Yeah, or when I'm cutting vegetables, I'm really worried about cutting myself. Weight loss. Yeah, these are all really like key things that patients come up with. Why did I put these on individual animations? But yeah, here's some other ones that people sometimes complain of. Oh yeah, you mentioned palpitations and diarrhea as well. Yeah, a lot of them, like, it's surprising the number of patients that just say that they feel on edge. Obviously, that can be a psychological problem, but it can also be a manifestation of hyperthyroidism. And don't forget that one of the earliest signs in females especially can be menstrual disturbance. So in hyperthyroidism, you have oligomenorrhea. What does oligo mean? Not very much, or irregular, yeah. Opposed to in hypothyroidism, where you'll get menorrhagia, which is heavy bleeds. Generally, if you're suspecting an endo problem, you should always, and it's a female patient, you should always ask about menstruation. Actually, scratch that. Any female patient, you should always ask about menstruation because it can give you a clue as to what's going on. So those are the symptoms the patient will complain of, and then you're going to examine. Wow, bad formatting on my half. You're going to examine the patient. So what kind of signs would you look for? So I'm going to split it up a bit. I'm going to split it into signs of hyperthyroidism generally, and signs specific to Graves' disease. So should we do signs for all of hyperthyroidism first? What would you see when you examine a patient? May hear a high flow murmur because hyperthyroidism is a hyperdynamic state. You might notice a fast, irregular pulse. Irregularly irregular, you would be looking for because it's quite likely to be AF. You might notice a goiter. What kind of goiter would it be? What would it feel like? You might notice sweaty palms, tremors, absolutely. And yeah, it's like a smooth, diffuse goiter across the midline of the neck, opposed to like a lumpy, painful one in other causes of thyroid problems. Tachycardia, yeah, you notice a high heart rate. Okay, what else? This is quite so like lots and lots of findings in a thyroid exam. You might notice hair changes, yeah. If you're exceptionally observant, you might notice hair changes. What else? There's one eye thing that happens in all hyperthyroidism, and then there's another eye, and the other eye things happen in just Graves. Yeah, so lid lag is super important. Does anyone know why you get lid lag in hyperthyroidism? Physiologically, it's quite useful to think about it. So connective tissue hyperplasia is what you get in Graves' disease rather than in just general hyperthyroidism. We'll get back to that in a minute. But effectively, with lid lag, hyperthyroidism, you can basically cause the effects of having like a massive adrenaline rush. Remember that the muscle that lifts up your eyelid is mediated by the sympathetic. So if you have sympathetic overstimulation, it's always going to be trying to pull your eyelid upwards. So when you test lid lag, you want them to close their eyelids. So that sympathetic muscle is going to be overactive and it's going to be pulling it back up. That's why you get lid lag in hyperthyroidism. But yeah, those are definitely like the most important signs you get in hyperthyroidism. So sometimes you can get ophthalmoplegia as well, but it's not very common, so ignore that. But don't forget to also check their reflexes. They get the hyperreflexia in hyperthyroidism. Graves specific ones. Exophthalmosis, yeah. What else? Thyroid acropathy, yeah. And pretibial myxedema. Those are the important ones. Why do you get hyperreflexia? Like the way I think about it is, again, you've got an overactive sympathetic system. You've got increased metabolic activity in your nerves. which causes like a hyperreflexic event. I'm not sure of the exact like pathophysiology. If anyone knows, let me know. And it's nothing to do with having an upper motor neuron lesion. It's to do with, it's probably due to the metabolic activity within the upper motor neurons. I'm not actually sure, sorry. Yeah, if you find out, let me know. I'm quite interested. And then we'll go through some signs. So what's this sign? What sign is this? So this could be thyroid acropatry. Yeah, but yeah, if you didn't have any context, you could just call this clubbing as well. So if we go through the causes of clubbing again, I know we've done it before, but it's quite useful. So you can split it up by system. So what are the different causes of clubbing? Except for thyroid acropatry. You already get that one for free. So you can have cardiac, respiratory, abdominal, and then general malignancies. Yeah, so gastro causes are things like inflammatory bowel disease. Malignancies tend to go along with respiratory, so you tend to get lung cancers. You can any like long-term inflammation causing bronchiectasis, and then you can get weird cardiac stuff like atrial myxomas, but like things like infective endocarditis can also cause it. So yeah, just remember to split that up by system so you can remember it a little bit easier. But yeah, in the context of thyroid disease, you would be wondering, is this thyroid acropatry? So thyroid acropatry goes along with Graves' disease, which is the commonest cause of thyrotoxicosis. If anyone gets confused by what's the difference between hyperthyroidism and thyrotoxicosis, they're exactly the same. It's just a word we use interchangeably. And because you get this antibody-mediated disease pattern, you get these extra features like the exophthalmos, the ophthalmoplegia. And the mechanism by which that happens is effectively what Nantish said earlier. You get connective tissue overactivity within the muscles of the orbit. So they tend to hypertrophy, and then you can't move them around as effectively because there's a limited amount of space in the orbit. So what type of I've already told you. It's a type 5 hypersensitivity reaction. It's like one of the few types of a type 5 reaction. Remember that type 5 is where you have antibodies activating a receptor opposed to just blocking or like stopping a receptor from functioning, which is the opposite to most other antibody-mediated conditions. Cool. So there's a few strategies we can use when dealing with hyperthyroidism. Like there's 3 of them to be precise. So does anyone know what those are? Yeah, so you can manage the symptoms themselves, which doesn't technically manage the disease process. But yeah, definitely beta blockers to control the AF, to control potentially some of the other symptoms that they might get. Yeah, so beta blockers and symptom management. What else? So you can do medical stuff like anti-thyroid drugs. You can do surgery. There's one other thing you can do, which is better than surgery. Yeah, radioactive iodine has fewer risks. Lugol's iodine. That's a funny word. So yeah, and then with the medical management, you've got 2 different approaches to how you can manage them medically. So what does anyone know what the 2 like methods we use are? So there's block and replace, and there's dose titration. Absolutely. So these are like the 3 big ones you need to know. Thyroid surgery is also very relevant. I just haven't spoken about it because I find surgery a bit boring. Sorry. Block and replace is where you completely knock out the thyroid gland, and all of the thyroid hormone in their system you're going to replace exogenously using thyroxine. I've wrote these down the wrong way around, sorry. And then titration is the opposite, where you start at 40 milligrams of carbimazole and you give them enough to maintain a euthyroid state. I'll correct these in the slides at the end before I send it out. So these are the opposite. The important thing you need to know about radioiodine is when can you not use radioiodine? So there is one absolute contraindication, and there is one quite important contraindication that's not absolute, but you would still consider avoiding it. Yeah, so pregnancy is an absolute contraindication. If they're pregnant, you do not use radioiodine, and that makes sense because radiation and fetuses do not go along together. So if they're pregnant, do not use radioiodine. Is it suitable for children? As someone who's done pediatrics, I should probably know this. I don't actually know. I can't see why not. I'll check. They won't ask you about it though. I'll check there. If they've got eye disease, technically you can still do it, but most people wouldn't. And for your exams, I would say still avoid doing it. Even though in the guidance it says it's a relative contraindication, but generally it can exacerbate the proptosis and the exophthalmos, so their eye might pop out or something crazy. So need to be careful regarding that. And then people with radioiodine, they will eventually need, you're eventually going to ablate the entire gland, so they're going to need thyroxine replacement. A classic exam scenario that comes up is someone who's had like ablation of the thyroid gland, and then they've been put on thyroxine. And then this came up in second year, but instead of taking their medication regularly, they just take it in one go, and they give you the blood test, and you need to be able to decipher that from the blood test. So I think it's one of the online Moodle scenarios. So I'd have a look through how you would distinguish hypothyroidism after radioiodine versus improper treatment adherence. So have a look at that. So that's like the main stuff for hyperthyroidism. Any questions about that? Except for, is it suitable for children? Let me check right now. Radioiodine in children. Potential long-term adverse side effects have yet to be observed in individuals treated, apparently. So I guess so. Can you have antibody negative Graves' disease? So that's really interesting. In Graves' disease, you can actually get both. Do you mean like Graves as in not, you have the opposite antibodies? Or do you mean just no antibodies at all? Sorry. Can you have clinical Graves but no TSH receptor antibodies? I'm not sure, but I imagine if the titer of the antibodies is low enough, you probably can. I'm not really sure actually. Sorry. There is one interesting thing. So people with Graves can have. So the two autoimmune thyroid diseases that you need to know of are Graves' disease, where you have hyperthyroidism, and you can have Hashimoto's, where you have hypothyroidism. In Graves, you can actually have both of those antibodies, so TSH receptor activating antibodies and anti-thyroid peroxidase antibodies. So in Graves can actually fluctuate between hyperthyroid, euthyroid, and hypothyroid. So the titration model is not actually that effective for these patients. So you can have all the different subtypes of antibodies with Graves' disease. So often they will just go for block and replace. Just an interesting thing. I'm not sure they'll ask you about that in exams, but in real life, that's what sometimes happens. We'll move on, but yeah, if you have any questions, you can continue asking them. So what is this? Any ideas? There are retinal hemorrhages on this diagram, and there are also cotton wool spots. There's one other finding. So this isn't actually diabetic retinopathy, but that is a good differential. There's one more subtle sign. New vessel formation. I think you could argue that there is new vessel formation. There are some hard exudates as well. The sign I'm looking for is even more subtle than those. It's not CMV retinitis. I will show you a picture of that later. Copper wire look. Yep. So there is, if you look at the artery, there's like a light, there's like a white line in the middle of some of the arteries. So that's the copper wiring. Yeah, there's one other sign. It's super subtle. You might not get it. So there's also AV nipping. So I'll go through what AV nipping is later on. We'll come back to it. But what are all of these signs indicative of? When you've got AV nipping, copper wiring, cotton wool spots, retinal hemorrhages, there's one condition that should jump out at you. And it's not diabetic retinopathy, sorry. Yeah, this is hypertensive retinopathy, yeah. So diabetic retinopathy, you can get all of these things as well. You're just less likely to get AV nipping. You're also a bit less likely to get silver wiring, but remember, you can get both diabetic and hypertensive retinopathy together. And you're probably like, Anush, why are you showing us pictures of like retinas, the ophthalmologies until next year? But this is one of the things you do actually need to know about the eye for fourth year. So you can grade hypertensive retinopathy into 4 stages. And you do actually need to know these 4 stages for your exam. So do you know what is the earliest finding in hypertensive retinopathy? Now that we've listed all of them in the chat, does anyone know what the first thing you'll notice is? So silver wiring is actually the first sign, not AV nipping, but yeah, good try. So silver wiring is effectively when the walls of the vessels in your eye, because you've had like, you've got this high blood pressure, they thicken so they don't explode. And that narrows where the blood's actually flowing. So you get like white lines on the outside and you get thinner space for the actual blood to flow through. Then you get the AV nipping. So with AV nipping, let me find an image for you. What normally happens when arteries and veins cross is that they cross at a 90-degree angle. In AV nipping, they no longer cross, they cross at a weird angle. That isn't normal. There's an image in the chat that demonstrates it for you. So with AV nipping, they're no longer intersecting at a perfect 90-degree angle. They curve out of their way when they intersect. Then you get your cotton wool exudates and you get flame and blot hemorrhages. What is the final stage of hypertensive retinopathy? It wasn't shown on that image. Papilledema, yeah. And then the thing with papilledema is you can have it without all of these signs of hypertensive retinopathy. If you have that, what are you thinking about? If you have papilledema without the other signs of hypertensive retinopathy? Yeah, so for those of you that love ophthal acute glaucoma, but you don't need to know that much about it. But more importantly, raised intracranial pressure can cause papilledema, and you should always think about raised ICP and intracranial pressure when you see glaucoma. So yeah, know this grading system. It's actually quite useful, and I think it does actually come up in exams. Is there a name for this grading system? Hypertensive retinopathy grading? I don't know. Does anyone know? The modified Shi classification, you definitely don't need to know what it's called. You just need to know the different stages. The other eye thing you need to know this year. So the important things to know in terms of the eyes this year are strokes that cause blindness. So like visual loss due to strokes. You need to know hypertensive retinopathy, diabetic retinopathy, and papilledema. Those are like the only 4 things you really need to know about the eyes this year. Oh, and giant cell arteritis. 5 things, sorry. But yeah, don't worry too much. There's tons of ophthal next year. So what is this sign? So this is papilledema. What about this tells you it's papilledema? How can you, what's like the distinguishing thing about papilledema? Yeah, you have the blurring of the optic disc's margins. So if we go back for a second, can you see how it's quite clear where the optic disc is in this picture? There's like a bright circle in the middle. That means that that's a normal optic disc. In papilledema, what happens is you just lose the margin of the optic disc. You can barely tell where it starts and where it ends. So that's the sign you're going to be looking for. And what's like the underlying mechanism for papilledema? What's actually going on in terms of like pathophysiology? Does anybody know? So what's effectively happening is, because of this massive raised pressure, whether it's intracranial pressure or it's pressure in the blood, yeah, there's a movement of water. The pressure effect basically kills the neurons at the end of the optic disc. So papilledema untreated can cause blindness eventually. So it is really important. Here's another sign for you. What sign is this? This is a lot more obvious than on the previous image. The chat has frozen or nobody's answering. Guess it is obvious to the trained eye. So this is copper wiring. You can see silver wiring is usually the term they use. The white lines in the top are blood vessels that have thickened due to the pressure. But yeah, if you see white lines on a retina, you should think about silver wiring, and you should think about, is this hypertension underneath? Yeah. This is this is the sign they're most likely to ask you about. I think this and the hemorrhages are the easiest to see on an image if they give you good images, but UCL classically gives you terrible quality images. Managing hypertension is one of the few treatment algorithms you need to know in detail. And I think the most important bit of it is, what do you do if you see a patient who's hypertensive in your clinic? Say you're in GP and your patient is hypertensive. What do you do? Correct question, how hypertensive? So let's say their clinic reading is 142/92. Yeah, you send them home on an ambulatory blood pressure monitor. What if their blood pressure was much, much higher than this? It was like 180 or 190 over like 130. Then what would you do? Then you would treat it immediately. You treat them and refer to cardiology, definitely. If you've got stage 3 hypertension, you should treat immediately. But yeah, if you've got this clinic reading, you're going to do an ambulatory reading. So you're going to see what the blood pressure is going to be like over the course of a day. And then there's two possible outcomes here. No, there's three possible outcomes here. Either it's normal and you do nothing about it. What are the other two possible outcomes? Yeah, is it stage 1 hypertension or stage 2 hypertension? Yeah, if it's really, really bad, you've already started treating it, so you don't need to worry about it. Yeah, so if this is normal, then if their ambulatory reading is normal, white coat hypertension means you don't need to treat it. It's just because they came to see you as the doctor and that kind of freaked them out. So don't worry about it. But yeah, if it's stage 1 or stage 2, you need to think about whether you want to treat it or not. So when do you treat stage 2 hypertension? And what is the cutoff for stage 2 hypertension? You always treat stage 2 hypertension. Any patient with stage 2 hypertension gets treatment. 150/90 is stage 2 hypertension, yes. And when do you treat stage 1 hypertension? This is the harder question. You don't always treat it. So if they're younger than 80, that could be one of the reasons. Yeah, what else could it be? So the important one that they like asking about is Q risk over 10%. If they have any kind of cardiovascular disease, diabetes, renal disease, any kind of major vascular disease, then you want to be treating their stage 1 hypertension as well. So yeah, know about when you treat hypertension. And here is the pathway. Oh wait, the first step in the pathway is, I've shown you one of the pictures, but what's the first drug you start them on, and how do you determine what the first drug you start them on is? This is the most important bit of the pathway. The rest of the pathway is not that important, I think. Yeah, you want to look at how old they are and whether they're diabetic or not. Not just type 2 diabetes, type 1 diabetes as well. And you know what the question I've asked you, I'm going to ask you is anyway. So if they're young or they're diabetic, you use an ACE inhibitor, and if they're older or they come from an Afro-Caribbean background, you use a calcium channel blocker. Why do we use an ACE inhibitor if they're diabetic? Renoprotective, yeah, absolutely, that's exactly why. So remember, with ACE inhibitors, when you start a patient on an ACE inhibitor, there's a rapid deterioration in renal function initially, but then it kind of slows down, and in the long term, it's actually beneficial for them. And most diabetic patients will go on to get some kind of renal disease in the future. So starting them on an ACE inhibitor is like really useful. Why do we use calcium channel blockers in Afro-Caribbean populations? I will not accept evidence-based as an answer, even though that is the real reason. Does anyone know theoretically why we do it? Yeah, so they tend to have problems with. I think it's to do with, they tend to have low renin levels, and they tend to have problems with the way that nitrous oxides dilate their blood vessels. So calcium channel blockers work a lot better. So that's the reason. It's a mixture of renin and nitrogen oxides in the bloodstream. You don't need to know that for your exams. It's just an interesting thing again. High renin would benefit from ACE inhibitor treatment if you think about it. If you think about the pathway. But yeah, older people also tend to have problems with like the nitrogen response of their blood vessels. So that's why calcium channel blockers are better for them as well. I think those are the important bits of the pathway, which drug you're going to start them on, because at the end of the day, they're all going to end up on the same drugs. Here is an image that I literally stole from PassMed that you can look through in your own time. But eventually, you're going to use all the drugs possible. And remember, you only move down the ladder if the hypertension hasn't resolved from your treatment. You're not going to just randomly start them on drugs. Another thing that sometimes comes up is when you add a potassium sparing, an aldosterone antagonist like spironolactone, versus when you use a beta blocker. So remember to always measure the potassium once they've been started on all of these other drugs. That's the only other really important bit of the pathway. Cool. Causes of hypertension. Most of hypertension is essential hypertension. We don't really know what's causing it. We can theorize about renin problems and nitrous oxide problems, but at the end of the day, it's idiopathic. Secondary hypertension is, however, very important, and there's lots of different causes. So what, if you had to categorize them, what are the causes of secondary hypertension? So you can have endocrine problems, yes. You can have cardiac problems, you can have renal problems, yeah. So the important ones are endocrine and renal. So let's split these up. There's also drugs, neoplastic, yeah. So there's lots and lots of causes of secondary hypertension, but I think these are the most important ones for your exams. So what kind of kidney problems should you be thinking of when you see someone acutely hypertensive? There's one really important one, and then there's two less important ones. Yeah, so renal artery stenosis is the most important thing to think about in terms of kidney problems. AD, PKD, and glomerulonephritis can also cause it, but glomerulonephritis is really quite rare, so focus on renal artery stenosis. What's like the classic presentation of renal artery stenosis? It's like three things. Flash pulmonary edema. Everyone loves flash pulmonary edema. It's such a buzzword. Yeah, what else? What else do you get as part of it? A history of PVD. I'm not sure what you mean by PVD. They might have a pre-renal AKI. What else? Peripheral vascular disease. So yeah. So remember that with renal artery stenosis, there's two different kinds. You can have like the atherosclerotic kind. So then they might have a history of peripheral vascular disease, but then some people might have the fibromuscular dysplasia, especially if it's like a young female, and they might not necessarily have a PVD history. So it depends on the patient, but yeah, definitely. But yeah, so the important things are flash pulmonary edema, pre-renal AKI, and hypertension. Those are like the three big things that you want to be thinking about with renal artery stenosis. Are there endocrine causes of high blood pressure? There's the really rare one that everyone remembers. Oh, I love it. Everyone puts it first. Pheochromocytoma, Cushing's syndrome, Conn's syndrome. Yeah. I didn't even put cons on here. I'm terrible. And then there's also congenital adrenal hyperplasia, but only one of the subtypes tends to cause hypertension. So pheochromocytoma, what is the best diagnostic test you can do for if you're suspecting a pheo? Urine metanephrines. First line or gold standard? Good question. First line, you tend to do urine metanephrines. Yeah, that's the first thing you're going to do. You would also do a scan eventually to see where the pheo is, but we try not to just scan everyone. Cushing's syndrome, I won't cover in detail, but it's very important and it comes up a lot. So congenital adrenal hyperplasia, does anyone know which subtype causes hypertension? You don't need to know that much about congenital adrenal hyperplasia, but if there was anything you needed to know about it, you need to know this type. HSD beta 2. So no, 11 beta HSD is the one you need to know about. So if we go, and then you have drugs. I've got a diagram to explain congenital adrenal hyperplasia. So if you look to the top right of the diagram, if you have a deficiency in 11 beta hydroxylase, you get This basically means that you cannot convert deoxycorticosterone and deoxycortisol into cortisol and corticosterone, and you can also not produce aldosterone. What this means is there's no negative feedback from the aldosterone and the cortisol on the adrenal gland, so you get tons and tons and tons and tons of deoxycortisol and deoxycorticosterone. All of these work in order to retain fluid, like they work both by constricting vessels and they also work in terms of retaining fluid, and eventually you get really, really high blood pressure due to these. So if you have a deficiency in that enzyme specifically, you'll get a really high blood pressure. The other subtype of congenital adrenal hyperplasia is where you lose 21-hydroxylase, which is a bit to the left. With that, you don't tend to get the crazy high blood pressure. So yeah, just remember that the 11-beta-hydroxylase one does cause an increase in blood pressure. Does that make sense? If it doesn't, let me know and I'll go over it again. And then, yeah, I brushed over drugs, but yeah, steroids can cause Cushing syndrome, and MAO inhibitors can also cause an increased blood pressure because of the way, by having increased monoamines in your circulation. I've got another SBA for you, right, poll. Apparently the polls. Okay, the polls have just decided to break, but write down an answer. Don't put it in the chat yet. Let people have a minute to think about it. Okay, cool. What do people think? Sorry, the poll isn't working. It's just decided to die. Bullet-shaped cytoplasm inclusion bodies. Okay. Cytoplasmic. Anyone else have any ideas? Or do you agree? Okay, so the answer is cytoplasmic inclusion bodies. What is the most likely diagnosis? When if you hear that someone's been bitten by a frantic dog, what is the one diagnosis you need to be thinking about? Yeah, rabies. Could this be rabies? Should I treat this person before they die? Is what you need to be thinking about. So rabies is pretty much like it's not really in the UK anymore. So if you see someone with a travel history to like Southeast Asia, Africa, most of the world except for the UK and Europe, you need to be thinking about rabies. And like the key things to know about rabies are summarized here. So it's an acute viral encephalitis. It's usually transmitted by dog bites, but like there are records of it being transmitted by bat bites and like raccoon bites. But the important thing for your exams is just dog bites. What are the key features of rabies? So there's three main things you need to know about rabies. Hypersalivation, hydrophobia. Yeah, those are the two big symptoms. And there's one other group of symptoms that you also need to think about. Someone else took control. Flaccid paralysis. So eventually it may often go to a flaccid paralysis. You might get psychiatric problems. But basically the issue with rabies is as soon as you have neurological symptoms, you're going to die. Like, the mortality rate after the onset of neurological symptoms is close to 100%. So you need to know, A, was the dog rabid? And you need to know what kind of prodromal symptoms that someone with rabies might get as well. So it's a super non-specific prodrome, but if you get these symptoms having been bitten by a dog, you should really see a doctor. If you've got a headache, if you get fever, if you're just agitated, remember that those are all prodromal features of rabies. And then, yeah, you got like the two headline features, which are hydrophobia and hypersalivation. And like, I can't highlight this enough, but as soon as you get those neurological symptoms, the hydrophobia and the hypersalivation and any kind of paralysis, you're going to die. Like, there's nothing you can really do about it. So you need to see a doctor if you're bitten by a dog. And when people go to travel, people will come to see you about travel advice in the future. I'm sure about it. You need to warn them about rabies. What's this? Yeah, it's it's a dog. Yes, this is a dog. That's great. Yeah, this is a rabid dog. It's obviously hypersalivating and it looks quite agitated. But yeah, the hypersalivation is the key point here. And what are these? The bullet-shaped in Negri bodies. That's exactly what these are. So the ones at the top are very much bullet-shaped. The one at the bottom is not so bullet-shaped. Why is that? Cut in another plane. Remember, whenever you're looking at histology, you can have different slices which can cut structures in half, etc. So yeah, I wouldn't rely on bullet-shaped being like the giveaway factor. But if they say this is someone's neuronal tissue and you see one of these things, you're like, oh, they might be dead. So that's rabies. How do you manage rabies? Assuming that they've not had their onset of neurological symptoms, because you can't manage it then. It depends whether or not they've had the vaccine. Absolutely, that's exactly what it depends on. Again, I'm harping on about it, but it is important. So let's say they've had the vaccine. What are you going to do? So they knew that they were going to an area with rabies. You give them a booster. You give them 2 further doses. That's exactly what you do of the vaccine, and hopefully that will protect against the toxins released. What if they haven't been vaccinated? What do you do then? So this is the important thing. Most people who go abroad aren't vaccinated for rabies. Just a heads up. Like, most people are not vaccinated. Anyone know what you do? So if they've not been vaccinated, what you do is then you give them the immunoglobulin and then you give them a full course of the vaccine. And this is kind of the reason why we don't, if you ever go to a travel clinic, which you will because you have a GP placement next year. Well, for your sake, I hope you don't, but you probably will. You'll sit in on a travel clinic and lots of people are going to areas where rabies is pretty common. Like, I go to India every year and like rabies is like super common there. But no one gets the vaccine because even if you have the vaccine, you still need extra doses. So there's very little point. The only people that get a rabies vaccine is if you're going somewhere and you're not going to be able to get to a hospital within 24 hours. That's the only reason you would get the rabies vaccine, because it gives you a bit of extra time before you get these neurological symptoms. So yeah, most people you see, if you ever see anyone with rabies, chances are they won't have been vaccinated for it. Cool. Does that make sense? So yeah, rabies is like one of the few like weird like conditions you don't get here that they might ask you about in the exam, but you don't need to know that much about it. So today we covered high blood pressure, hyperthyroidism, and rabies. As usual, I'm going to ask you to fill out the same feedback form so we know what to improve. And you can obviously, like, I'll pick stuff to cover from your feedback. So let me know if you want anything specific covered. I'll put it in the group. Yeah, so the full course of the rabies vaccine is three injections. Yeah. There were some questions earlier that I forgot that I said I'd look up. Yeah, if you have any questions, I'll stick around for like 5 minutes or so, but I'm just going to try and find the stuff from earlier to answer it. Teams is being slow. Also, like, I think a few people have been quite overwhelmed by how much online teaching stuff there is. So if you want us to cut down to just one session a week, we can do that. It's up to you, or we can continue doing two. Just let us know what you want. I think Ahmed is planning to do something on Monday as well, so that should be good. Any other questions? I think my chat is really slow, even if you did ask any questions. It's just a pain. Just to recap, diabetic retinopathy, hypertensive retinopathy, stroke-inflicting blindness, and GCA. Yeah, I would say that's like the main like eye stuff you need to know about for 4th year. I'm trying to think if there's anything else. No, I think that's like that's pretty much the main stuff. Do we need to know the different stages of diabetic retinopathy? Oh my God, yes. So there's like, so UCL in 5th year uses a different classification to the past med one, which is different to the current one that the Royal College uses. So I'm not too sure about the stages, but I would say to know the signs at least. Oh, I said I would show a picture of CMV retinitis. Sorry, Nanthi, you just reminded me that. I said I would do that. What are cotton wool exudates? So cotton wool exudates are basically what's happening is when you have ischemia to part of the retina, that part of the retina will die and stuff from the retina leaks out, and they're effectively these cotton wool spots that you get due to the cells dying. That's what those are. If someone has hypertensive retinopathy, does the management change other than to control their hypertension? So you don't need to know too much about the management of the retinopathy, but the mainstay is actually just managing their hypertension. You might, so if they have lots of neovascularization or they have like some of the end stage hypertensive things, you might consider some endothelial growth factor blockers. So you stop the neovascularization. But most of the time, the mainstay of treatment is just to control the hypertension. Most people do not have stage 3, stage 4 hypertensive retinopathy. As I'm sure you're happy to know. So this is what CMV retinitis looks like. So the way they call it is pizza pie fundus. So it's super similar to what like a stage 3 hypertensive retinopathy looks like. And then next year you'll learn about some other conditions that also look like this. But the things you're going to be looking, what kind of things would you be looking for in the history of someone with CMV retinitis when you were talking to them before you even look at the eye? It's like, what kind of things are you going to look for? Yeah, history of immunosuppression. So you should definitely be doing that. And anyone with CMV retinitis, what's an important aspect of the history that you'll take? Yeah. So you're going to be looking for HIVs. So don't forget to take a sexual history. Generally good practice is like taking a sexual history is quite useful because lots of STIs can. I'm on gum, and like a lot of the STIs can mimic other systemic conditions, so it's quite useful. Yeah. If you see like really bad, if you see like what you think is a CMV retinitis, they will tend to give you a bit of a history of what's going on. Like, are they immunosuppressed? Do they have HIV? So I wouldn't worry too much about distinguishing them. I'm going to stop the recording there.